Bismillahirrahmanirrahim. Now we are going to continue with the seventh session of our musculoskeletal system. So it's about the smooth muscle contraction and relaxation. Do not depend on the action potential. That is very important. That in contrast to the skeletal muscle and the cardiac muscle, the smooth muscle relaxation is not dependent on the action potential. Secondly, it does not require the membrane depolarization to contract. The actin filament, actin is a thin filament, myosin is a thick filament. The pattern is same, but these muscles don't require the membrane depolarization for the contraction. Myosin is heavy, and myosin is what? Myosin is divided into heavy and light chain. So there are two types of myosin: myosin heavy chains and myosin light chain. Myosin light chain modified in the smooth muscle to control the contraction. Smooth muscles are thick filament regulated. In contrast to skeletal muscles, which are thin filament regulated by modification of tropomyosin on the actin filament. So basically, in the smooth muscle, in the skeletal muscles, we were regulating the skeletal muscle, the cardiac myosin, we were regulating the thin filaments, which are the actin filaments. So we were regulating the actin filaments by the tropomyosin. Over here, we are going to regulate the thick filament, which are myosin. So basically, in the smooth muscles, are thick filament regulated, while the striated muscles, both striated muscles, which are cardiac and the skeletal muscles, those were thin filament regulated. MLC phosphorylation, that is myosin light chain phosphorylation. Remember, over there was, so in the case of striated muscles, both cardiac and skeletal, we saw that there was calcium binding to the troponin C, and the calcium was the modulator of the binding. But in this case, the phosphorylation of the myosin light chain is going to regulate the muscular contraction. So myosin light chain phosphorylation will regulate the contraction and tone. Only phosphorylated myosin light chain interacts with the actin. So for the myosin light chain to interact with the actin, we require the phosphorylated version of that. Myosin light chain kinase phosphorylate the myosin light chain. Okay, and myosin light chain kinase is activated by the calcium calmodulin. So the calcium calmodulin pathway is being used in the smooth muscle cells. Okay. Myosin light chain kinase phosphorylate the myosin light chain. Got it. Moving forward to the next page, regulation of the smooth muscle contraction and tone. How do we do that? Calcium is in the cell through L-type calcium channel, which is blocked by the dihydropyridine calcium channel blockers. So dihydropyridine calcium channel blockers are acting on the periphery, right? On the vessels and the smooth muscle and the viscera and stuff like that. The dihydropyridine calcium channel blockers do not act very effectively inside the heart. For that, we need non-dihydropyridine, which are like the verapamil and stuff like that. Amlodipine, which is the dihydropyridine calcium channel blocker, works effectively on GIT and other smooth muscles, for example, in the vessels. For example, in the vessels. Myosin light chain phosphorylation. So there are two things: regulation of smooth muscle contraction and tone is done by the calcium in the cell through the L-type calcium channel, which is blocked by the dihydropyridine calcium channel blockers, and the myosin light chain phosphorylation. Acetylcholine causes the smooth muscle relaxation by an indirect mechanism through its action on the endothelium of the cells. Okay, so through its action on the endothelium of the acetylcholine or bradykinin, which are bind to the receptors, they will cause the calcium from where? Okay, so they will cause the calcium to be stimulated, and the calcium will then lead to the arginine conversion of arginine into nitric oxide. So by nitric oxide synthase, the L-arginine will be converted to nitric oxide. Then nitric oxide will be diffused into the cells, and then the nitric oxide will perform its action. So what was I saying? Acetylcholine causes smooth muscle relaxation by an indirect mechanism through its action on the endothelium of the cells. It is very important that this blue surface lining is the endothelium, and under that we have the myocyte. So because of this coverage, because of this lamination of the endothelium, the acetylcholine is responsible for the smooth muscle relaxation. But suppose in the areas, in the blood vessels, maybe if the endothelium is removed, or if it is not present, or if it is damaged, and the acetylcholine can reach directly to the smooth muscle cells, so then it will bind to the nicotinic or the muscarinic receptors on the smooth muscles, and then it will be causing contraction. So that the endothelium is basically a protection from the acetylcholine, so that acetylcholine cannot reach the myocytes directly to cause the contraction. If the endothelium layer is patent, then relaxation will be occurring. So how does the relaxation occur? That the acetylcholine will cause the calcium influx into the cell, and that calcium will catalyze the conversion of L-arginine into nitric oxide by nitric oxide synthase. And nitric oxide will diffuse into the cell, and that will convert the GTP into cGMP. Cyclic GMP will positively upregulate the myosin light chain phosphatase. That is, it will dephosphorylate the myosin light chain. Here you can see that the myosin phosphate will be dephosphorylated into myosin and actin. It will be dephosphorylated, and if the myosin is dephosphorylated, if the myosin light chain is dephosphorylated, this will not let the contraction to happen, and that will result in relaxation. So nitrous oxide result in relaxation. But in contrast to that, if there is action potential coming and L-type voltage gated calcium channels are there. So remember one thing, that the smooth muscle fibers do not require, they do not depend on the action potential, and they do not require the membrane depolarization to contract. But suppose an impulse is reached there, we'll see the detail of that later on, that an impulse is there and the calcium channels, the voltage dependent calcium channels, L-type voltage gated calcium channels have opened. The calcium will move inside the cells. When the calcium is entering the cell, there will be an increased calcium calmodulin complex. That increase in the calcium calmodulin complex will cause the myosin light chain kinase to be activated. That kinase will convert the myosin and actin into phosphorylated myosin plus actin. And now this is pro contraction, so that will cause the contraction to happen. So increase in calcium will cause contraction. So remember it like that. Moving forward to the equilibration. Okay, I remembered one point. Maybe there is a picture of that. Okay, over here. So it was type of muscle fibers. There was a table about that, if you could get it. Guyton and Hall. There was a table in Guyton, but I can't find it right now. So there we have this table. Here you can see now. Okay. So the characteristic of the skeletal muscle fibers. Now we are not talking about smooth muscle fibers. There was a point from the last session. That was the type of the muscle fibers. So I just came across a mind. So I just here we are on the table. So the characteristic: slow or oxidative type 1, and fast oxidative and fast glycolytic, these are type 2A and type 2X. So we'll keep it till here, and we'll also read that, but the concerned or high yield topics are type 1 and type 2A. So the myosin ATP activity in the slow type 1 fibers, which are the endurance muscle fibers, which are the paraspinal muscles, which give you the posture. So the slow type are myosin ATP activity will be slow, speed of contraction is slow, resistance to fatigue is very high. Oxidative phosphorylation, then oxidative phosphorylation capacity, that is high for the slow oxidative type 1 fibers. The enzyme of anaerobic glycolysis are low. Mitochondria are a lot, there are a lot of mitochondria. Capillaries are also many. Myoglobin content is high, and the color of fiber is red. These are slow oxidative fibers. Then let's talk about the fast twitch fibers, type 2A fibers. Myosin ATP activity is high, speed of contraction is fast, resistance to fatigue is intermediate. Okay, oxidative phosphorylation capacity is high, enzyme for anaerobic glycolysis is intermediate, mitochondria are many, capillaries are many, myoglobin content is high, and the color of fiber is also red. So this is these two are like comparable things. The difference is between type 1 and type 2X. So this is type 1 fiber and this is type 2 fibers, which we usually find in the first year or maybe the step 1 exams. So forget about this one, center one, and we'll keep this in our focus. So myosin ATPase activity, in the fast glycolytic or the fast twitch fibers, the myosin ATPase activity is high, speed of contraction is fast, resistance to fatigue is low, oxidative phosphorylation capacity is also low, enzyme of anaerobic glycolysis is high, mitochondria are few, capillaries are few, myoglobin content is low, color of fiber is white, and glycogen content is high. So keep this table in your mind if you like want to do that, if you have a lot of brain space, so you can remember this thing. So coming back to our PDF, now we are going to discuss about equilibration movement of charged ions under the physiological conditions. So under the physiological conditions, the ions like sodium, potassium, chloride, and calcium, we'll talk about them one by one. Sodium, charge is positive, major location is extracellular location, equilibrium potential is plus 60 millivolts. In all the cells, across all the cells, the equilibration potential is plus 60 millivolts for sodium. Okay. Equilibration and the movement at minus 70 millivolts. Equilibration movement at minus 70 millivolts, that is threshold potential. Extracellular gradient drives the sodium into the cell, making membrane potential more positive. Listen, there are a lot of beautiful videos on YouTube about this concept, the equilibration potential and equilibrium movement. You can listen to them, right? I'm just giving you my concept or my kind of mnemonic, which I have made for myself, that at equilibrium right now in your body, when you are listening to my video right now, in this point, all the cells of your body have plus 60 millivolt equilibration potential for the sodium. What does that mean? that your cell has sodium, potassium, ATPase, right? There is pumping of through 3 sodium outside for 2 sodium to be brought inside, for the 2 potassium to be brought inside. 2 potassium are coming inside and 3 sodium are being pumped outside for some unknown reason, but that is happening. And that has happened to such an extent that right now at equilibrium position, your cell membrane has plus 60 millivolt potential that is generated by sodium ions alone. If we had only sodium ions, so those sodium ions would have created an action potential across the membrane of plus 60 millivolts, right? I hope it is clear, and if it is not clear, kindly go listen to the videos which are explaining this concept very beautifully. So, or you may also read the BRS physiology from which I have learned this concept. So this is a beautiful concept. And secondly, equilibration potential at movement at minus 70 millivolts is a threshold potential for the impulse to be transmitted across different cell surfaces. So at minus 70 millivolts, what is the direction of flow of a particular ion? That is something that we are going to discuss now in this column. So for the sodium, the extracellular gradient derives the sodium into the cell, making the membrane potential more positive. For the potassium, the charge is positive, major location is intracellular, equilibration potential is minus 90 millivolt. Like for the potassium, again the same concept is that right now across all of your cells, most of your cells, the potential, if it would be generated by potassium alone, it would be minus 90 millivolts. And equilibration potential at minus 70, which is the threshold, intracellular gradient of the potassium, intracellular gradient derives the potassium out of the cells, making the membrane potential more negative. Then for the chloride, the charge is negative and the position is mainly extracellular, so the only intercellular ion is potassium, and the cells are the bags of potassium, as Dr. Najib states that. So chloride is the location is extracellular. The equilibration potential is minus 75 millivolts. Equilibration movement at minus 70 millivolts is extracellular gradient derives the chloride into the cells, making the membrane potential more negative. Calcium, it is a positive ion. The location is mainly extracellular. The equilibration potential is plus 125 millivolts. The equilibration movement at minus 70 millivolts is extracellular gradient drives the calcium into the cells, making the membrane potential more positive. Moving forward to the bone formation. Okay, now we are done with the physiology of the muscular contraction, and now we're going to talk about the bone formation. So bone is formed by cells and matrix. Cells can be either osteoblasts or osteoclasts, and matrix can be of the collagen or calcium. What is bone matrix? Now we're going to talk about the matrix. So the bone matrix, extracellular component of the bone, synthesized by the osteoblasts. So the matrix is being secreted by the osteoblast. Type 1 collagen, that is type 1 collagen plus hydroxyapatite calcium plus phosphorus. So there will be 3 components to the matrix. First one is type 1 collagen, second one is hydroxyapatite calcium plus phosphorus. So there is a calcium, a very tough formula for this one, so remember it to be hydroxyapatite calcium plus phosphorus. No, it is hydroxyapatite which is formed by calcium and phosphorus. I'm sorry. So there is type 1 collagen. There are 2 things only. Okay, the first thing is type 1 collagen, and the second thing is hydroxyapatite, that is calcium and phosphorus. Okay, bone matrix is first synthesized as osteoid, that is a non-mineralized soft kind of a bone or a gooey structure, non-mineralized bone matrix. It is mostly protein that is laid down by the osteoblast. So for the first time when the bone is being formed, like suppose in the infant, not in the infant, not in the fetus when the bone is being formed, or when you have a bone fracture and the bone is being reformed. So whenever the bone is formed again, firstly an osteoid will be formed. That is a non-mineralized bone matrix, and that is mostly protein laid down by the osteoblast. Bone matrix is then mineralized with the calcium and phosphate. So firstly we'll form the soft structure, and on that soft structure will cause the accumulation of calcium and phosphate. Talking about the enchondral ossification. Enchondral ossification means inside the enchondral literally means inside the cartilage, because chondral is cartilage and end means inside. So bone of axial skeleton, appendicular skeleton, and the base of skull. What is axial skeleton? Axial skeleton means like your vertebral column and the ribs. That are basically the bones in the central axis of your body. Appendicular skeleton is like with the upper limbs and the lower limbs, and skulls, the bones which are at the base of the skull. So these are the bones which are being formed by the enchondral ossification. That is, the cartilaginous model of the bone is first made by chondrocytes, like when the infant is born, while when the bones have not yet calcified completely. At that time, we have a cartilaginous model for almost all of these bones. Osteoclast and osteoblast appear later with woven bone and then remodeled to lamellar bone. Okay, so these are the steps. Firstly, we'll have a cartilaginous model for that bone. Osteoclast and osteoblast later replace with woven bone and then remodel to the lamellar bone. Okay, what is woven bone and what is lamellar bone? Woven bone is the first bone formed, also called as the primary or immature bone, disorganized collagen fibers, and it is a weaker structure. In adults, woven bone occurs after the fracture in the or in the Paget's disease. So normally the woven bones are not present in the adults. They're present either in the intrauterine life or maybe in the neonatal or the infantile period. Okay, in that time the person can have woven bones, but for the adults, woven bone are not a normal thing. Woven bones will only be present in case of a fracture or in the case of a Paget's disease. What is lamellar bone? Lamellar bone is layered, organized, and stronger bone. So woven bone and lamellar bone are exact opposite of each other. It is the primary structure, and then the secondary structure is the lamellar bone. Lamellar bone is the foundation for the lamellar bone to be formed. Okay, defective in the achondroplasia. We'll discuss this condition, achondroplasia. So the enchondral ossification is defective in case of achondroplasia. Moving forward, what are mucopolysaccharidosis? Hunter's and Hurler syndrome are mucopolysaccharidosis. Inability to metabolize the heparin and dermatan sulfate. Chondrocytes are destroyed by the accumulation of these substances. Short stature and malformed bones. So chondrocytes are destroyed by the accumulation of these substances. The person will have short stature and malformed bones. What is membranous ossification? Bones of calvarium skull, facial bones, and clavicle, they are undergoing membranous ossification. Woven bones formed directly without cartilage. So here firstly there was a cartilaginous model on which the osteoblasts were making, the osteoclast and osteoblasts together, they were making the woven bone, and then the remodeling happened to form the lamellar bone, stuff like that. But in the case of membranous ossification, woven bone formed directly without cartilage. Embryonic connective tissue matrix is directly converted into a bone, later remodeled to form the lamellar bone. So the first structure to form is the woven bone, and on the woven bone the lamellar bone will be formed. Okay, embryonic connective tissue matrix is directly converted into bones. Okay, then what is the cell biology of the bone? So first we will talk about osteoblasts, and then we'll move forward to osteoclasts. Okay, we'll see a picture of Uworld as well. So osteoblasts build the bone by secreting the collagen and catalyzing the mineralization in the alkaline environment via the alkaline phosphatase. Differentiate from the mesenchymal stem cell in the periosteum. So they build the bone and catalyzing the mineralization in alkaline environment via alkaline phosphatase. Okay, they differentiate from the mesenchymal cell in the periosteum. Got it. Osteoblastic activity is measured by the bone alkaline phosphatase. So whenever there is increased level of alkaline phosphatase in the blood or in the serum, you have to check for the GGT simultaneously, because if there is GGT and ALP rise simultaneous rise in the both gamma glutamate transferase and the alkaline phosphatase, so the origin is the liver. But if the GGT level is normal but the ALP is elevated, or you check specifically for the bony ALP, then in that case the source of alkaline phosphatase is coming from the bones. Creates the alkaline media for the calcium deposition. The alkaline phosphatase will create the alkaline media for the calcium deposition, because the hydroxyapatite, I guess, that precipitates in the alkaline environment, because the alkaline material, the alkaline stuff, whatever it is, that will be precipitating in the alkaline media, because it will be soluble in the acidic media. It will not be precipitating, it will precipitate in the alkaline media only. Similar is for the uric acid, like uric acid stone which are formed in the kidney. If your urine is acidic, so the uric acid stones will be precipitating. If your urine is alkalinized, the uric acid will be dissolved in that alkaline environment, and then that will be passed into the urine. That is why the person who is suffering from the uric acid stone problem, we give him the sodium bicarbonate, we give him the alkalinization agent, so that the urine becomes alkalinized and the uric acid stones become dissolved into that. So remember that concept. Now hydroxyapatite is an alkaline solid or alkaline material. So for that thing to precipitate, we need the alkaline environment, and that alkaline environment is provided by the bony ALP or bony alkaline phosphatase. Osteocalcin, major non-collagen protein in the bone matrix, marker of the bone remodeling. So osteocalcin is the marker of the bone remodeling, and it is the major non-collagen protein in the bone matrix, and type 1 procollagen. So these three things are going to give us the measure of the activity of osteoblast, that is bone ALP, osteocalcin, and type 1 collagen, type 1 procollagen. How to differentiate bone specific and other type of alkaline phosphatase? Electrophoresis and specific monoclonal antibodies. Heat denaturation is another way to denature to differentiate between the two. Pardon me. How to differentiate between bone specific? Okay, yeah. This is something I was talking about. that either check the level of GGT or maybe do the electrophoresis, and specific monoclonal antibodies to check if it is specifically ALP coming from the bone or from other sites, and then heat denaturation can be done. It is another way to differentiate between the two. Bone specific alkaline phosphatase is easily denatured by the heat, that is bone boils. So bone specific alkaline phosphatase will be denatured by the heating, while the other alkaline phosphatase won't be degenerated this easily. Then moving to the osteoclasts. Osteoclasts, they dissolve or crushes the bone by secreting the H positive and collagenases. So due to the release of H positive ions and the collagenases, the osteoclast will be dissolving the bone. Acidosis stimulates the osteoclast and may cause hypercalcemia from the bone breakdown. Okay, acidosis will, so they secrete H positive, and if there is acidosis, the osteoclasts are stimulated in the acidic environment, and they may cause hypercalcemia from the bone breakdown. That is why in the conditions where we have the acidosis, the calcium level of the blood increases because of the bone resorption, because acidosis is going to stimulate the osteoclastic activity. Differentiate from a fusion of monocyte macrophage lineage precursor. That's so cool, because for the osteoblast we saw that they were differentiated from the mesenchymal cell in the periosteum. That is the origin of the osteoblast. But for the osteoclast, they differentiate from the fusion of monocyte macrophage lineage precursors. Okay, rank receptors on the osteoclast are stimulated by the rank ligand secreted by the osteoblast. So rank receptors will be stimulated by the rank ligand. The two most important factors in the osteoclast differentiation include, the first one is macrophage colony stimulating factor, because it is coming from the precursor cells to the macrophages and monocytes. So resultantly, what do we have? Macrophage colony stimulating factor, MCSF, the receptor for activated nuclear factor kappa B or rank L. Rank L and MCF, or macrophage colony stimulating factor, and rank L, these two things are the major determinants of the major determinants of osteoclast differentiation and activity. The receptor factor of the nuclear factor kappa B ligand rank L stimulates the development of mature multi-nucleated osteoclasts. Blocked by osteoprotectin OPG, which can act as a decoy receptor, bone turnover is regulated by the ratio of OPG to rank L. Bone turnover increases with the osteoprotectin when the osteoprotectin is low and rank L is high. So osteoprotectin, suppose we'll see that later on, by the way. I guess there is a picture. So this is rank ligand versus osteoprotectin. So here you can see that when the rank is bound to the rank ligand, there will be multinucleated osteoclast, and osteoclast will be like dangerous, and that will cause a bone resorption at a very high rate. But if the osteoprotectin is binding the rank ligand, so rank ligand can no more bind to the receptor. So if the osteoprotectin is acting as a decoy receptor and that is binding to the rank ligand, so resultantly the when osteoprotectin is binding there, so rank ligand interaction won't be there, and if the interaction is not there, resultantly we have decreased activity of the osteoclasts. Coming back, so they were saying that bone turnover is regulated by the ratio of osteoprotectin to the rank ligand. Bone turnover increases when the osteoprotectin is low and the rank ligand is high. Estrogen maintains the bone mass in the premenopausal women because of increased osteoprotectin by the osteoblast and stromal cell. When the estrogen level is high, estrogen causes the increased production of osteoprotectin by the osteoblasts and the stromal cells and decrease rank on the osteoclast precursor. So two things happen by the estrogen. First one, that there is osteoprotectin excess, and secondly, there is a decreased level of rank on the osteoclast surface. What is denosumab? Monoclonal antibody used in the treatment of postmenopausal osteoporosis. It works in a manner that is similar to the osteoprotectin by binding the rank ligand and blocking the interaction with the rank receptor. So denosumab is an antibody that acts in a similar fashion to the osteoprotectin. It does not allow the fusion of rank ligand to the rank, because the denosumab will bind the rank ligand, and the rank ligand is bound, so the interaction won't be there. Resultantly, the osteoclast activity won't be seen and the osteoporosis will be slowed down. Markers of osteoclastic activity: first one is tartrate resistant acid phosphatase. Okay, second one is urinary hydroxyproline, and third one is urinary deoxypyridinoline. Pyridinoline. Deoxypyridinoline. That is the most reliable one. The most difficult name is the most reliable one. So tartrate resistant acid phosphatase, then urinary hydroxyproline, and then urinary deoxypyridinoline, the most reliable one, marker for the osteoclastic activity. So now we have these cells. So the hematopoietic stem cell gives rise to the osteoclasts, while the what was that? Periosteal, yeah. Periosteal mesenchymal cell give rise to osteoblast. Periosteal, the mesenchymal cell in the periosteum will give rise to the osteoblast. So hematopoietic stem cells, what is that? PU1 and macrophage colony stimulating factor that will result in the differentiation of the osteoclast precursor. Osteoclast precursor will cause the activation of the osteoclast, and osteoclast will undergo, like multiple osteoclasts will fuse together to form the fusion activation, and survival of the osteoclast will lead to the osteoclast activation. So there they have written the low osteoprotein to rank L ratio. When the osteoprotein is low and the rank L is high, so there will be a low OPG to rank L ratio. Increased osteoclast formation and activity, so increased remodeling of the bone will be seen. In the case of osteoblast, the osteoblast is coming from the periosteal mesenchyme, and that will differentiate to form the osteoblast. No, then this is not osteoblast. I'm sorry, this is osteoblast over here. These are two situations in which, in first situation when the OPG to rank L ratio is low, and here we have OPG to high OPG to rank L ratio. So let's come to this. This is also an osteoclast with a C. The osteoblast is present just over here. So osteoblast is representing the rank ligand which is presented to the osteoclast, and they can do the activity. Now over here, if the osteoprotein, so the rank gives the signal by NF kappa B for the fusion activation survival. Okay, so we were talking that when the osteoprotein is there, so osteoprotein will bind to the rank ligand, and that will not allow the interaction of the rank ligand to rank receptors. So resultantly, osteoprotein competitively bind the rank ligand and prevents its binding to the rank. High osteoprotein rank L ratio decrease the osteoclast formation and survival. What are osteocytes? Osteocytes inhabit the lacunae, and I'm done with this one. Yeah. So osteocytes inhabit the lacunae and have long intracanalicular processes that extend through the ossified bone matrix. So there is a picture of osteocytes. There is an osteocyte like this. So this is an osteocyte. This is the bone cell. This is not either bone forming or bone blah blah blah, bone resorbing. This is just a bone cell. The structure of the bone is formed by these cells. These are called as osteocytes, and they are present inside the lacunae. Coming back, the lacunae, the osteocyte inhabit the lacunae and have long intracanalicular processes that extend through the ossified bone matrix functions. These cytoplasmic processes send signals to exchange the nutrient and waste products with the osteocytes within neighboring lamellae via the gap junctions. Okay. Sense the mechanical stress and sends signal to modulate the activity of surface osteoblast, thereby helping to regulate the bone remodeling by producing the sclerostin and fibroblast growth factor 23, FGF23. The osteocyte serve to maintain the structure of mineralized matrix and control the short-term release of deposition of calcium, that is calcium homeostasis. The plasma calcium concentration directly dictates the metabolic activity of the osteocytes. Parathyroid hormone and calcitonin indirectly influence their metabolic activity. The parathyroid hormone and calcitonin indirectly influence their metabolic activity, while the plasma calcium concentration directly dictates the metabolic activity of the osteocytes. I'm sorry. Here you can see the bone structure and the osteocytes. I guess this again is the picture from Uworld, maybe, but I have not seen this picture. So here you can see the monocytes and lymphocytes and osteoclasts are coming from these monocyte structures, monocyte precursor cells. Then we have a mesenchymal cell, the osteoblast are on the surface, which are originating from the periosteal mesenchyme. Okay, so mesenchymal cell, the periosteal mesenchyme give rise to the osteoblasts. Then we have osteocytes. Okay, so this is the lamella, and the blood vessel is below that. These are lacunae. Lacunes are basically the cavitations which are present inside the bone. Like these are very small lacune. So in the lacunae, we have these structures like the osteocytes. So osteocytes have projection going on in all the directions, and they're communicating with the surface as well as with each other. And then we'll have canaliculus, like the bony canal through which the osteocyte projections are connected to each other. Then we have bone remodeling key substances. Firstly, we'll talk about parathyroid hormones. So they are the substances which are responsible. These are the substances which are responsible for the remodeling of the bone. At low intermittent level, once daily bolus of triparatide treating the osteoporosis exert the anabolic effects, building bone on the osteoblast and osteoclast. What's triparatide? Triparatide. I guess it is an analog of the parathyroid hormone. So parathyroid hormone, let me see that. Triparatide, what's that? Triparatide. So triparatide is a recombinant fragment of the human parathyroid hormone consisting of its amino. So basically, it's an analog of the. It's a recombinant fragment of human parathyroid hormone. Keep that in mind. We don't need to remember this type knowledge. Coming back. So parathyroid hormone at low intermittent levels only once daily bolus of triparatide, which is a recombinant form of the parathyroid hormone, in treating the osteoporosis, exerts anabolic effects, building bone on the osteoblast and osteoclast indirect. Okay, so direct effect on osteoblast and indirect on the osteoclast. Okay, chronically, because I guess osteoblast will signal or inhibit the activity of osteoclast somehow, but direct effect on the osteoblast and indirect effects are on the osteoclasts. Chronically, increased parathyroid hormone level, for example, primary hyperparathyroidism, cause catabolic effects, osteitis fibrosa cystica. So if parathyroid hormone is low in the body, low level of parathyroid hormone stimulate the osteoblasts, right? And low level will stimulate the osteoblast, resulting in an anabolic pathway for the bone formation, while the catabolic effect of the parathyroid hormone are seen at the high level, like in the case of osteitis fibrosa cystica, when we have catastrophically high level of PTH in the case of a chronic kidney failure. So whenever we have a chronic kidney disease or chronic kidney failure, in that case we have chronically high PTH level, which is also called as secondary hyperparathyroidism. So in that case, the picture of bone that we get is osteitis fibrosa cystica, and that is a catabolic effect of a very high level of parathyroid hormone. Then we have, it is osteoblasts, not osteoclasts, that have high PTH receptors. PTH receptors cause PTH parathyroid hormone cause osteoclasts to increase the production of rank ligand and monocyte colony stimulating factor. These two factors stimulate the osteoclastic precursors to differentiate into bone dissolving and mature osteoclasts. Parathyroid hormone decreases the release of osteoprotectin. So parathyroid hormone will decrease the release of osteoprotectin. Estrogen inhibits the apoptosis in the bone forming osteoblast and induces the apoptosis in the bone resorbing osteoclasts. So the estrogen inhibits the apoptosis in the bone forming osteoblasts and induces the apoptosis in the bone resorbing osteoclasts. So basically, estrogen is in the favor of apoptosis of the osteoclast. Estrogen is in the favor of osteoblast. I was going to say that. Estrogen favors the osteoblast formation so that the premenopausal women are stronger in comparison to the postmenopausal women, and the bones of the postmenopausal women have undergone the osteoporotic changes because of absence of estrogen. Stimulates osteoprotectin synthesis in the osteoblast, increase osteoblast and decrease osteoclasts. Stimulate the osteoprotectin synthesis by the osteoblast. Okay, so firstly they are causing the osteoclasts to be undergoing apoptosis. Secondly, they will cause an increased level of osteoprotectin, so that increase in osteoprotectin level will decrease the activity of the osteoclast and also decrease the osteoclast number. Decrease macrophage colony stimulating factor and the rank production on the surface of the osteoclasts will also decrease the bone resorption activity, because we need this factor for the proliferation and this factor for the activity of the osteoclasts. Causes the closure of epiphyseal plate during the puberty. Estrogen deficiency, surgical or postmenopausal, increases the cycles of remodeling and bone resorption. Okay, increase the cycle of remodeling and bone resorption that leads to increased risk of osteoporosis. What is osteocalcin? It is coming from the osteoblast and it is a marker of bone remodeling. Although osteocalcin is coming from the osteoblast, but it is the factor, it is the marker for the bone remodeling. Okay, not bone resorption. Remodeling means the formation of new bone. So that is, osteocalcin is coming from the osteoblast and it is a marker for the bone remodeling. Sclerostin. Glycoproteins secreted by the osteocytes inhibit the osteoblastic bone deposition. Serum levels increased during the bed rest, reduced by the parathyroid hormone. Anti-sclerostin antibodies may alleviate the osteoporosis. So serum level increased during the bed rest and reduced by the parathyroid hormone. Anti-sclerostin antibodies may alleviate the osteoporosis. FGF23, that is fibroblast growth factor 23, secreted by the osteocytes in response to hyperphosphatemia, inhibit the renal phosphate reabsorption. So secreted by the osteocytes in response to hyperphosphatemia, they inhibit the renal phosphate reabsorption, lower the serum levels and decrease vitamin D synthesis. Unregulated secretion of the tumor causes hypophosphatemia and osteomalacia. Okay, so unregulated secretion of the tumor causes the hypophosphatemia and osteomalacia. Treat with phosphate and vitamin D supplementation. So okay, I have to read that once again, I was zoned out. So fibroblast growth factor 23 secreted by the osteocytes in response to hyperphosphatemia. Whenever there is hyperphosphatemia, FGF23 is released. Okay, they inhibit the renal phosphate reabsorption, Renal phosphate reabsorption is inhibited by the FGF23, lower the serum level and decreases the vitamin D synthesis. Unregulated secretion by the tumor cells, that is hypophosphatemia and osteomalacia. Okay, so in three conditions it is unregulated. Unregulated secretion of the FGF23 from the tumor cell. No. If that FGF23 is being produced by the tumor cells, in that case we'll have hypophosphatemia and osteomalacia. So we have to treat with the phosphate and vitamin D supplementation. What is calcitonin? Calcitonin is produced by the parafollicular C cells of the thyroid gland. Calcitonin inhibits the osteoclasts. It ultimately decreases the bone resorption, which can lead to an increase in the bone mineral density. The effect of calcitonin is opposite to that of the parathyroid hormone. The effect of calcitonin is opposite to that of the parathyroid hormone. Now we'll talk about the musculoskeletal pathology. Okay, on to the pathology. What is achondroplasia? Most common cause of dwarfism is achondroplasia. Pathophysiology: activating mutation of the fibroblast growth factor receptor 3. Okay, decreases the chondrocyte proliferation, decreased endochondral ossification, decreased longitudinal bone growth, and ultimately there will be short stature. So basically, what is achondroplasia? Achondroplasia is defect in what? The defect in the activating mutation of the fibroblast growth factor 23 that decreases the chondrocyte proliferation. So the FGF, fibroblast growth factor receptor 3, FGF receptor 3 has an activating mutation. So chondrocyte proliferation will not be there. And if the chondrocyte proliferation is not there, so the bones which undergo enchondral calcification will not be formed. Like there will be a decrease in chondral calcification, decreased longitudinal bone growth, the length of the bone will not be increasing, and this will result in the short limb. Okay, so if you have seen Game of Thrones, so there was a very small Lancaster, I don't remember the name of that person, but he looked like this. So he has achondroplasia. More than 85% mutation occurs sporadically. Autosomal dominant with full penetrance, homozygosity is lethal. So more than 85% of mutations occur sporadically in the fibroblast growth factor receptor, and they are activating mutations. So more than 85% of the mutation will occur sporadically, and autosomal dominant with full penetrance. It is an autosomal dominant disorder, and 100% penetrance is there. Like the person who has that mutant allele will have the disease, and if there is a homozygosity for that, it can be lethal. Membranous ossification is not affected. Large head relative to the limb. So the head will be large in reference to the limb and associated with increased parental age. Okay, I guess dwarf Lancaster GOT. I am talking about this person, Tyrion Lannister something. So this person has achondroplasia. So if you could see this picture and then you look at this picture, so they look very similar to each other. So here you can see that the characteristic finding of achondroplasia are macrocephaly, frontal bossing, mid-face hypoplasia, then rhizomelia, shortened limbs, especially proximally. So proximal shortening of the limbs will be there. Then trident hands are seen. Trident. What is trident? Let me see that. Trident. So this thing, okay, this is a trident, and there will be trident hands. Okay, keep it in here. So trident hands will be there. Okay, you can see three projections, 1, 2, and 3. So they look like a trident. And then we have genu varum. We have seen that genu varum, in which the lower limb is adducted. The lower limb is moved inside, and the knees are moved outside. So that is genu varum, bowing of the tibia. Then we can see there will be a frontal bossing, dorsal kyphosis. The kyphosis means exaggerated thoracic curvature. Spinal stenosis will be seen. Okay, and we have seen the manifestations of that. Spinal stenosis can be due to the osteophytes formation, or can be due to the hypertrophy of the ligamentum flavum, or maybe due to some other reasons. So spinal stenosis will be seen, and then lumbar lordosis, which means that lumbar curvature is exaggerated, and trident hand can also be seen. Moving forward to osteoporosis. Introduction. The two major types of bones present in the adult skeleton are trabecular and the cortical bones. Trabecular bones are called as spongy bones or the cancellous bones. They compose only 15% of the total skeleton by weight, metabolically more active because of its large surface area. An example is the vertebral body. So vertebral bodies contain more of the trabecular or the cancellous bone. Cancellous bone is like this. This is the cancellous bone picture. and they are like 15% or even less than that of the skeleton by weight and metabolically active. Okay, so this is spongy bone basically. Cortical bones, the long bones, contribute by serving as mechanical support and side of the muscle attachment. Most of the appendicular skeleton is cortical bones. Example is shaft of the long bone. So spongy bones are the ones, or the trabecular bones, which are responsible for the hematopoietic functions and metabolic functions of the body, while the cortical bones are the site of bony attachment. Okay, definition. Mass in the trabecular spongy bone, mass loss in the trabecular or spongy early and the cortical bone late, and interconnections despite normal bone mineralization and lab values, serum calcium and phosphate. So in the osteoporosis, whenever the disease occurs, we have a loss of mass in the trabecular first, that is spongy bone will lose the mass first, and then the cortical bone will lose the mass, and interconnections despite the normal bone mineralization and lab values of serum calcium and phosphate. Although the serum calcium and phosphate levels are normal, it is the bony mass that is losing, that is being lost firstly from the trabecular and then the cortical bone. The mineralization is intact, okay, or the mineralization is normal, you may say that. The serum calcium and phosphate level are normal, but the problem is with the loss of mass. Causes most commonly primary due to the increased bone resorption related to the decreased estrogen levels and old age. Most commonly primary due to the increased bone resorption that is related to the decreased estrogen levels and old age. Risk of osteoporosis is based on peak bone mass attained in the early adulthood, okay, and rate of bone loss that follows thereafter. Peak bone mass is achieved by 30 years of age and is based on genetics, for example, vitamin D receptor variants, diet, exercise. Thereafter, slightly less than 1% of the bone mass is lost each year. Bone mass is lost more quickly with lack of weight bearing exercise, for example, space time. What? Weight bearing exercise. So, what do they mean by that? Space travel. Weight bearing exercise means like weight lifting in the gym and space travel. Poor diet or decreased estrogen, for example, menopause. So in these situations, although 1% of the bone mass happens every year, but if it is happening more quickly than usual, so you must suspect that the person is not doing the weight bearing exercises, or he is not going to space travel usually more often. He is having a poor diet and decreased estrogen, for example, menopause. Most common cause of osteoporosis are senile and postmenopausal. It can also be secondary to drugs and other medical conditions, for example, hyperthyroidism, and multiple myeloma and malabsorption syndromes. Hyperthyroidism, multiple myeloma, and malabsorption syndromes. Uworld point is peak bone mass reached at 30, determined by genetic factors, physical activity, and nutritional state. Genetic factors are responsible for up to 80% of variation in the peak bone mass among individuals. Physical activity, mechanical forces, stress stimulates the bone growth. Heavy weights better than high reps. So if you are lifting heavy weights, then doing more reps, that will increase the bone mass. Nutrition state, calcium and vitamin D increases the bone mass and parathyroid hormone reduces it. Risk factor for the osteoporotic fractures. There are some non-modifiable risks which you can't change, and then there are potentially modifiable risks as well. So non-modifiable risks include advancing age, female gender, female sex, white, Hispanic, and Asian ethnicity, personal or family history of fracture. Why is family history of fracture important? I don't know, but even if there is a personal history of fracture, or the person belongs to a family of the people who have frequent fractures, like the person, they are the family of stuntmen, so they have frequent fractures. So that is the non-modifiable risk factor. He can't change his family. Potentially modifiable risk factor are decreased physical activity, low body weight, poor calcium and vitamin D intake, excessive alcohol and tobacco use, premature menopause, and glucocorticoid use. Medication associated with the osteoporotic fractures. Medication, so which are causing the osteoporosis. So these are the medications which are associated with the osteoporotic fracture. Firstly, we'll talk about the anticonvulsants that induce the cytochrome P450, for example, the phenobarbital, phenytoin, and carbamazepine. They increase the vitamin D catabolism and resultantly osteoporosis will be there. Aromatase inhibitors and medroxyprogesterone, they decrease the estrogen level. GnRH agonist, they will decrease the testosterone and estrogen, because GnRH agonist, for example, leuprolide, that will cause, normally we need a pulsatile secretion of the GnRH. If there is a constant secretion of GnRH, so there will be a decreased level of estrogen and testosterone, because the constant level of GnRH is an inhibitory stimulus to the FSH and LH release. Then we have proton pump inhibitors that decrease the calcium absorption. Glucocorticoids, unfractionated heparin and thiazolidinediones, they also decrease the bond formation. Glucocorticoids, unfractionated heparin and thiazolidinediones, they will decrease the bond formation. Okay, so moving forward to the Uworld point, glucocorticoids promote the osteoporosis by increasing the osteoclast differentiation and activity, decrease the osteoblast activity and synthesis of the bone matrix, and decrease intestinal action of the vitamin D in promoting the calcium absorption and increasing the parathyroid hormone levels. Okay, so they will increase the osteoclast differentiation and activity, decrease the osteoblast activity and synthesis of the bone matrix, and decrease the intestinal action of vitamin D in promoting the calcium absorption and increasing the parathyroid hormone level. Patients taking prednisone daily for more than 6 months can develop osteoporotic bone changes, and 30 to 50% of the patients on prolonged systemic glucocorticoids may develop pathologic vertebral body fractures. Osteoporosis can also occur due to systemic absorption of topical glucocorticoids such as inhaled glucocorticoids used in the treatment of asthma, and proton pump inhibitor increases the risk of osteoporosis. Insoluble calcium, for example, calcium carbonate requires an acidic environment for proper absorption, and acid suppressing medications can interfere with the process. It presents with what are we talking about? We're talking about drug-induced osteoporosis that can present with low-impact fractures, pain, cervical kyphosis, and lab values. Not only drug-induced, but all kind of osteoporosis present with these symptoms. Firstly, low-impact fractures. First, most common osteoporotic fracture is the vertebral compression fractures. Okay, because the weight of the body is held by the vertebral body when the person is standing. So the first most common osteoporotic fracture is the fracture to the vertebral compression fracture. Acute back pain, loss of height, and kyphosis. So the person who is having osteoporosis will become short because there is a loss of height. The height is being maintained by the vertebral column. Where the vertebral column is getting short, the person is also getting short. Okay, vertebrae and trabecular bone mostly. First, vertebrae are trabecular bones mostly. So firstly, the first fracture is to the trabecular bone. Second most common fracture is to the hip fracture or the femoral neck fracture. The neck of the femur consists 50% trabecular and 50% cortical bone. So in such bones which have 50% trabecular, 50% cortical, the cortical bone is forming the outside, while the trabecular bone is present in between the cortical bone. So then distal radial fracture, that is the Cooley's fracture. The Cooley's fracture, it is also called as the dinner fork deformity something. Okay, so we'll see that later on. But the distal radial fracture, the Cooley's fracture, is the third most common site. First most common site is vertebra. Second most common site is the neck of femur. Then the Cooley's fracture can be there. Fragility fracture, for example, fall from the standing height, minimal trauma at hip or vertebra, so that can also cause low impact fractures. Pain in the thoracic or lumbar spine. Cervical kyphosis, that is Do-Weger's hump. Okay, cervical kyphosis, that is Do-Weger's hump. Kyphoscoliosis, lumbar lordosis, and loss of height can also be seen. The labs are normal, like calcium and phosphate and the parathyroid hormone, everything will be normal in the osteoporotic patient. That is a very important thing to remember, and also a confusing thing. So here you can see that we are talking about the normal intervertebral disc is present over there. So intervertebral disc is like looking like this, and normal intervertebral foramina are like this. When there is osteoporosis, so there will be compression fractures. What do we mean by that? The central expansion of the intervertebral disc, because the peripheries are being compressed, so there will be a central expansion. On top of that, restricts the intervertebral foramina. Okay. So there will be intervertebral foramen that will be restricted. So you can see the extent of intervertebral foramen is shortened, as you can see in this picture. It is diagnosed by X-ray. So diagnosed by X-ray will show thin cortices, loss of trabecular bone, and biconcave codfish vertebrae. Biconcave or codfish vertebrae. So codfish like fish look something like this, you know. So biconcave like this and this. So vertebra will become like this. So biconcave vertebra will be seen. It is biconcave. It is okay. That's biconvex. Biconcave vertebra looks something like this. Over here and over here. Where's codfish? So this is a codfish, and I don't know how is it a codfish vertebra. Codfish vertebra looks something like this. Okay, so make your own set of analogies that how this thing is looking like this thing. I can't decipher that, but if you can, so that's good for you. This is codfish vertebrae, but the point is that biconcave vertebra like this and this, because there's compression pressure ongoing. Okay, then we have bone mineral density and measurement of the DEXA. Dual energy X-ray resorption absorptiometry. You are not supposed to remember this name, but bone mineral density measurement by the DEXA at the lumbar spine, total hip and the femoral neck with a T-score of less than equal to minus 2.5. So it is diagnosed by the X-ray, which will show thin cortices and loss of trabecular bone. Biconcave vertebra will be seen. The codfish sign will be seen, and on the bone mineral density, bone mineral density can be measured by the DEXA scan. And if the at these sites, like lumbar, total spine, the femoral neck, and the T-score, if the T-score is less than equal to minus 2.5, in that case, we diagnose this one. Screening, one-time screening recommended in women more than 65 years of age. Okay, one-time screening is recommended for women who are more than equal to 65 years of age. Prophylaxis, regular weight-bearing exercises, adequate calcium and vitamin D intake throughout the adulthood. Treatment, all the patients' lifestyle modification, weight-bearing exercise, avoidance of heavy alcohol, smoking cessation, calcium and vitamin D supplementation. First line therapy is bisphosphonates, which are preferred for the initial treatment. We'll see bisphosphonates. SERM, that is specific estrogen receptor modulators. For example, raloxifene, that is second line treatment. First one is bisphosphonate and second line treatment is SERMs. Then we have triparatide, the parathyroid hormone analog, I guess. Triparatide. Okay, just give me a second. Triparatide. What's that? No, triparatide was over here. Triparatide. Yep. So this is triparatide. Let's come back. So triparatide is over here. Triparatide can also be given as a treatment of choice for the osteoporosis. Then calcitonin, denosumab, monoclonal antibody against the rank ligand and hydrochlorothiazide. Patient with a hypertension and osteoporosis. Patient with a hypertension and osteoporosis, when they are given hydrochlorothiazide, so because hydrochlorothiazide is a calcium sparing or calcium preserving drug, calcium sparing diuretic, so it causes the increased absorption of calcium when the hydrochlorothiazide is given. So the person is having osteoporosis, on top of that he is having hypertension, so hydrochlorothiazide is a very favored drug. Because Uworld point is about the thiazide diuretic, this will be the last point in this session. Increased calcium resorption in the distal tubule. Okay, studies have shown that use of thiazide is associated with higher bone mineral density and reduced fracture risk, and many experts recommend them to be treated for the treatment of hypertension in the patients who are at risk of osteoporosis. Increased calcium resorption also causes hypocalciuria, which may prevent the recurrent renal stones in some patients. Okay, we'll keep it till here and we'll continue with the osteoporosis, marble osteopetrosis in the next session. Until then, Allah Hafiz, take care and fi aman Allah.